Welcome to the 9th episode of PD Exchange, the Peritoneal Dialysis podcast, where we discuss the latest and the best of PD literature. I'm your host, Dr. Nikhil Shah, a nephrologist at the University of Alberta, Edmonton, Canada. And with me is my co-host, Dr. Jeff Pearl, a nephrologist at St. Michael's Hospital, University of Toronto, Canada. Dr. Pearl is also the editor-in-chief of the journal PD International. For today's episode, we are talking about dialysis access for peritoneal dialysis, and both our guests know a thing or two about this topic. Dr. Dr. Crabtree is a general and laparoscopic surgeon and is affiliated as the visiting faculty with Division of Nephrology at the Harbor UCLA Medical Center. He is the chairperson for ISPD's PD University for Surgeons, and he is also the associate editor for PD International. And we have Dr. Matthew Oliver. He's a nephrologist and division head at the Sunnybrook Health Sciences Center in Toronto, Canada. His primary research focus is on optimizing use of peritoneal dialysis in the home. He's the former president of the ISPD North American chapter and co-leads the North American PD Catheter Registry. Today, the topic of discussion is the paper titled A Multi-Institutional Observation Study of Outcomes After Catheter Placement for Peritoneal Dialysis in Japan. The paper is published in the November issue of PDI, and Dr. Crabtree has written an editorial on the same. Welcome to both of you, and I will hand it over to Jeff.
Thanks very much, Nikhil. And I do feel a little bit like I'm in the midst of PD Access royalty. Dr. Crabtree, who's really revolutionized the way we approach PD access and really has got it down to a science. And Matt, who is one of the co-principal investigators of the North American PD Catheter Registry. It's really great to be here. And it's not by design that we have an all-male panel or a manel. This just happened to be by fluke, as I'm sure you'll attest from our previous podcasts. We've been hopefully successful about having a pretty good gender balance. And this was a complete accident, and we'll certainly make it up for future podcasts. So I apologize in advance that our authors from Japan couldn't be here. But hopefully, Dr. Crabtree, if you wouldn't mind over a few minutes, just to summarize the main points of the article in PDI. And I also want to say that this article is really a jumping off point for tonight's discussion to discuss the issues of PD access in general. And hopefully we'll be picking both of your brains on this topic, hearing some updates from the registry perhaps, and also asking you about some thoughts for some direction the PD community should be going. So maybe John, if you wouldn't mind telling us a little bit about the article and some of the key findings.
Okay, Jeff, thanks. This was a multi-center study of outcomes after PD catheter placement in Japan, and they contrasted their results with the ISPD guidelines on PD access. The study was comprised of 49 collaborating institutions. They performed 409 catheters implantations during the study period. Most of the catheters were placed by nephrologists, 69%, and surgeons placed about 30% of the catheters. And most of the cases, about 87%, almost 89%, were placed by open surgical dissection or laparotomy. Laparoscopy accounted for only about 12% of the catheter placements. The remarkable thing about this study is that the nephrologists placing these catheters had a catheter patency of about 93.7% at 12 months. And so this is really outstanding. It really actually is close to what we expect with advanced laparoscopic techniques, which have shown a patency rate at about 12 months of greater than 95%. They also looked at catheter or technique survival, and they determined that in the 12-month period that they had only a 15.3% technique failure rate. So that too was also good.
So my question is, did they experience a lot of center-to-center variability in that outcome, or was it a pretty consistent, were they pretty consistent results, or did they look at that at all?
They did not look at it because they felt that some of the centers had such small numbers, they didn't feel like it would be a meaningful comparison.
Right. And I think that that's something that I think we all sort of anticipate we might see, at least, and maybe Matt can comment, maybe from the North American registry. Do you think you get the sense that there is center-to-center variability in PD access outcomes?
We've analyzed this a little informally across programs, because part of the objective of the registry and our grant is to look at these variations more formally. But yes, there is variation among sites, and there's a sense too that maybe some sites are more skilled at managing the complications too. So there's two things sort of going on, which is the sort of pure incidence of the complications, if you like, and then also how they're managing through those complications, which, because if you look at the endpoints for this study, it's either invasive procedures or revision procedures or PD catheter removal, which would coincide with termination. So it's kind of a surrogate for termination of PD. So, they have to get to that point in order to hit the endpoint. But if someone is able to skillfully manage around that endpoint, then you can get variation from that as well.
Right. So it's really interesting that this paper came out when it did, because I'll just highlight that there was recently a paper in JASN that was published, e-published in the last month or so, and that was using U.S. claims data. So this was only patients who had Medicare insurance, I believe, and I'm sure some of the Americans there can correct me if I've made any errors in that, and looked at PD catheter procedures in 3 groups of patients: those who had surgical catheter placement, those who had interventional nephrology placement, and those interventional radiology. And what was interesting about those findings is that the follow-up procedures were much higher for nephrology and radiology placed catheters than surgical catheters. And so, of course, what really stands in complete contrast to the experience in Japan is the overwhelmingly higher use of surgical catheter placement, for example, in the United States than Japan. And I just wondered, John, your feedback, is the take-home message that PD catheters should be placed only by surgeons in the US based on that experience? Or do you think some of the outcomes that were achieved in Japan by nephrology-placed PD catheters can be reproducible in sort of other environments?
So I really think the outcomes were based upon the training that the provider had in placing the catheter. So with that in mind, I think that really any of the specialties, whether it be surgeons or interventional nephrologists or radiologists, should be able to produce outcomes based upon the extent of their training.
Yeah, and you showed a really great picture. Received quite a bit of a social media discussion about a group of training nephrologists, I believe, sitting around some chickens, practicing their access placement. I hope they had a lot for dinner that night, and the chickens didn't go to waste. But I think that you definitely piqued our interest about the extensive training that takes place in Japan. Maybe you can describe that as a model for what we could potentially replicate in other parts of the world.
Well, I think what's important about it, regardless of the model that you're using, is that the hands-on aspect of it. You can talk about catheter placement or preach to people who need to improve their techniques, but unless you provide them a hands-on opportunity to develop their skills, you're probably not going to move the needle much in improving the outcomes.
Yeah, I want to jump in here and ask a question to John. If these are residents or trainees in nephrology or nephrologists, the whole North American trend is biopsies are being done by radiologists, sperm caths are being inserted by radiologists, and the movement away from procedures is disturbing. I trained in India and I used to do all these procedures, and then I used to put in PD catheters, the straight ones. So the question is, if that is the key, that training is so important, hands-on, is that something that needs to be incorporated? We are adding a new procedure to the people who are resistant to this?
So maybe the three of you can answer this question. You know, the number of ESKD patients that you have, do you think that you have room in your practice to have a more active role in placing catheters?
I'm going to say, you know, this is a tricky one, and we could have a debate about to what extent PD access placement should be something that's taught in nephrology training programs. And I certainly can tell you from my experience, I don't have the bandwidth to expand my practice to placing PD catheters. Having said that, in my program, we place a lot of advanced laparoscopic catheters that are embedded. And the only way that I could get that program up and going is if I took on the responsibility of catheter exteriorization, not nearly as time consuming as placing catheters. But I would say that, you know, we do have an evolving field of interventional nephrology that's heavily focused on the training of vascular access procedures. And we know that that expertise out there exists, and there is interest among the nephrology community for interventional procedures. And I would say that's really the group of nephrologists that I would suggest should have as equal opportunity and access to PD access training and develop their skills as, for example, they do for the vascular access procedures. And for example, at my center, nephrologists don't place catheters because we have interventional radiology. But Matt, at your center, you definitely have Dr. Bourne August, who is a nephrologist that has a keen interest in placing catheters. Maybe you can describe a little bit about that at your program.
We actually have three methods. One is Bourne August, who's doing it sort of in a procedure room, ultrasound guidance. We have radiology doing it with ultrasound and fluoroscopy. And then we've also have advanced laparoscopics. We have three techniques. Some of our challenges is maintaining sort of volumes for the different operators. I mean, I think the general feeling is that a combined options or having both options that in your program is perhaps ideal, because there's other issues, medical issues, which can determine whether someone should have one versus the other. For example, are they well enough to undergo a general anesthetic, so sometimes a percutaneous is better in that regard. I just wanted to mention one thing, though, is that most of the percutaneous operators in the registry are using fluoroscopy to place the catheters, to confirm position of the catheter tip inside the peritoneum. And sometimes that is a limitation. So, you know, not every nephrologist can get access to a fluoroscopy suite, at least in the Canadian system. So I just wanted to add that wrinkle in there.
Yeah. But right now, there's no formal training of PD access insertion across nephrology fellowship programs. You sort of have to seek that out as an apprenticeship among centers within Canada that do place a PD access, you know, via nephrologists.
It's very popular. It's very popular in our program. A lot of fellows come to us and ask if they can do it. But one challenge is volume. So I'd be interested in John Crabtree's thoughts on volumes. But just for example, ours Jane has mentioned, who's a big percutaneous inserter in London, that you need about 50 cases. He felt to be really, really expert. So it's very difficult for a trainee to get that kind of level.
And in that paper in Jason that I point out in the US, the number of insertions per operator was very, very low. So it really, I think, you know, bolsters your point about volume and outcomes. John, what are your thoughts?
Yes, I agree with what Matt has said about the volume of procedures. There have been studies that have looked at this specifically for PD catheters and suggest that really you don't start developing expertise or economy of motion until you've done 20 cases at least. And so the volume is important. I wanted to kind of go back. You mentioned about, you know, interventional nephrology programs being more inclined toward hemo access instead of PD access, and I wonder what your thoughts are of what why the direction of interest is toward hemo versus PD?
I think I don't have an answer for you, and I'd love to maybe pose this on social media, Nikhil, and ask on social media, why is interventional nephrology not as enthused about PD access? We should. I mean, you two, you, John, and Matt, on behalf of the ASN home dialysis subcommittee of the COVID-19 response team, made some pretty strong arguments why, and you've reiterated this to Matt, why we need to make sure that we have non-surgical access opportunities. Operating room shut down, PD access was not prioritized as a procedure. And so programs that had access to either radiology or nephrology placed catheters, I didn't know, Matt, that you have the luxury of both, could not halt, their PD programs were not halted dead in their tracks. They could have an alternate route. So I think that one of the lessons I've learned from COVID-19 is we definitely need to have a non-surgical access pathway to complement a surgical access pathway. And I agree that programs that have access to both have a win-win situation. But back to your question, why is there no interest? Well, money talks, I'm sure. And so I guess the question is, I don't know the current landscape for reimbursement for vascular access procedures versus reimbursement for PD access creation. But I certainly would surmise that if there was some increased reimbursement that went to PD access creation, that it certainly might pique the interest of some interventionalists to consider it. Of course, a lot of people trained at a time in the US prior to 2011 when home dialysis was declining in its utilization. And I think that that also is another factor that probably also resulted in less expertise in PD access insertion by nephrologists, where, we were part of the fistula first boom, and there was a huge emphasis on getting surgical vascular access. And with that came the procedures that needed to maintain patency. But I think all the stars are aligned for us to reevaluate this and ask that question and hopefully move forward with better resources. But as Matt said, it's kind of like a cyclical problem. If you don't have people that are inserting them now, then where are you going to send people to train to get the expertise to do it? So we kind of have to have a rethink about this and, figure out where are the centers of excellence where people can actually go and learn. Because I would say that to say you're going to have an interventional nephrology training program and learn how to put in PD access, I would hazard that very few programs in the country could support such a training program with their current volumes. So we've got to kind of have a workaround to think about that. And then that just continuously feeds the problem of the next group of people we're training.
Mm-hmm. I think you're correct in about the finances, the reimbursement probably motivates our interest in the type of access that we're prone to pursue. In the United States, I can tell you that all of the PD access procedures reimburse at about half of what you would get for making an AV fistula. So there's a real problem there, I think. And the problem is more than just trying to get CMS to tweak the reimbursement schedule. It's because they do have a very rigid process in which they decide about so-called relative work values that they use to compare to other procedures performed, so that they'll never be able to justify increasing the PD access rates based upon their current process. What we have proposed is an outcomes-based incentive program based upon the outcomes, so that they get Medicare could essentially increase their outcomes by reimbursing more, but they could do this by rewarding the provider with an incentive amount that's added to their usual reimbursement if their outcomes are satisfactory over some set period of time. But we haven't really got any movement on that. We have proposed that with some of the large dialysis organizations who have other incentive programs to try to include this, but haven't really made any progress with that.
That just opened up a whole can of worms for me in a line of questioning. But I will say that if CMS and other government bodies are listening, a very wise nephrologist wrote a paper called "Choosing PD Reduces the Incidence of access interventions," and from a downstream of impact of placing a PD catheter, you might be less likely to require access interventions down the road compared to an AV fistula. So the opportunity cost of increasing reimbursement for PD access may still be more cost effective than, let's say, a surgical AV access or maintaining somebody with a catheter. And that wise author is on our podcast right now. Matt, do you just want to describe your findings in that paper? I think that's a real golden, I think that's one of my go-to golden papers to pull out when I'm talking about some of the benefits of PD from an access perspective.
Well, thanks for mentioning that and remembering that, Jeff. I mean, early in our work, we did a lot of work around isolating a population which was eligible for both peritoneal dialysis and hemodialysis. Roughly about 70% of patients are considered eligible for PD, and then the 30% that are not are usually considerably sicker. So if you have to sort of take them out of the analysis in order to get apples to apples, and then we use that sort of lens to look at all kinds of different outcomes and mortality. And I've always been interested in access. And in that paper, it showed that patients undergoing PD, patients who chose PD, who could have chosen either one, they had less invasive need for procedures. And so we don't often, sometimes we forget about that. Like I do a lot of vascular access work as well. And it strikes me how often we see people who have, say, very small veins, and it's obvious that their HD access is going to be a challenge right from the get-go, and yet they're not redirected into PD. So often I say to people who we see in access clinic for fistulas, oh, your veins are very small, you're looking at a brachiobasilic fistula right off the bat, why don't you look at PD again? Because you could get 3, 4, 5 years of PD without even ever having to enter your vascular system. So I think that's a really critical message that people need to understand. Patients too. I don't want to go too far here, but patients, all those patients in hemo that undergo many vascular access procedures, and you can't think of a sort of a PD person in general who would need that level, of intervention.
And I want to just the second thing that John said, that's great, Matt. I completely agree with you. The second thing, John, is you sort of proposed the carrot strategy of incentivizing outcomes, if I understood you correctly. Matt, in Canada and in the UK and in many other countries, it's very easy in quotation marks, and you can describe your trials and tribulations with the registry. But in general, your Sunnybrook, you have your access, you have your CKD patients. They get PD access, they come to your program. You can track the journey from start to finish. We can track the journey at St. Michael's. In the UK, it's similar. In the US, the journey is complicated, for example. You start off in a nephrologist's office, then you end up in a surgeon's office who might place the catheter somewhere else. Then you end up in an outpatient dialysis clinic. And there's all this fragmentation in the transition process and in the care, getting somebody established on PD. Could we even, maybe John, your comments, and then Matt from the North American PD Catheter Registry, could we even build a system that could track PD access outcomes? Let's not talk about what we're measuring, but is that even a feasible goal? And I've said this many times that we track, programs track peritonitis. We're reporting KT over V urea for what that's worth, for example, and don't get me started on that soapbox. But something so as fundamental as important to the patient experience like PD access, we don't track in the US, and we ought to. Is that even something we can do you think?
I'm wondering if it would be best tracked by the large dialysis organizations than by the government itself. The government is also giving large dialysis organizations incentive programs. Why couldn't that program that's extended to the LDOs also include following the outcomes of these PD catheters?
Right. But they don't often see patients till they first present for their treatments, correct? So we might even miss people, for example, that get a catheter and never even make it to an outpatient home dialysis clinic. And that's the challenge, I think.
Oh, yeah, it is.
And maybe, Matt, you can comment on that from the registry, and maybe your lens from trying to collect this data in Canada and the US on similarities and differences and the feasibility of doing something like this large scale in the future?
It is a little more challenging in the United States. We had programs where they just simply couldn't follow the people, or they couldn't enroll the patient because they knew they couldn't follow them. So that was a bit unique. But this makes me think of one of the challenges that if people read this paper, you'll see that there's kind of many different ways to calculate these outcomes. And in terms of which outcome is included, what is the consequence of the outcome, and does it require a procedure to terminate therapy, and then what's in the denominator. So I think what I did like about this paper is that they used a very similar definition to the guidelines, which is the endpoint was flow restriction or pain, and that led in this case to procedures. In our registry, we also use termination, but it's a pretty clean outcome. I would like to see it separated, just to put my 2 cents in, between pain and flow. I think those are two different things. It would be nice to report those separately. But I think that's something we might be able to zone in on that's pretty simple, pretty important, and most programs could measure it.
No, that's a really good perspective.
Mm-hmm.
I want to point out that we're PD International, and I know we've talked a lot about North America based on all of us being from North America. But PD Access is having a moment on the journal circuit. In this recently in Kidney International reports, the group from the UK published their experience with the UK catheter study, looking at surgical versus percutaneous. I think they called it medical, surgical versus medical PD Access placement, showing slightly improved outcomes with medical, perhaps if I remember correctly. Particularly in the domains of infection, which I find really surprising. And I wanted to know if either of you could comment on why there might be differences in infection risk with percutaneous strategies versus surgical. I had some trouble understanding.
I'm familiar with that paper. And
yeah.
One of the things that was interesting is that they tried to get at programmatic intervention. So the medical the programs that had a medical model rather than just a surgical model, they did have more frequent review of peritonitis rates and auditing of peritonitis rates. They also had some other differences in terms of their volumes and the amount of urgent PD. So that part of it was, is it the technique itself, or is that the medical model is in programs that have other things going on, which is reducing the complications? Which is in part why it was a complicated analysis if you read that paper.
Yes, the statistics are challenging. And I would say that it is another paper, along with the paper from Japan, that sort of cements the idea that we really need to think about having various methods of PD access insertion available.
The rates of complications were quite high.
Yes.
Now, they looked at a broader range of complications, not just pain and flow. But if you looked at the rate of the curves, most patients were having complications, I think, by a year or something. Can't remember exactly, but not this 93% patency we're seeing.
And that's tricky. At what point do you sort of say this isn't an access related problem? The longer you're out from a PD access and established on PD, the more a problem becomes less related to the method of insertion and more to other noise that's going on. So I think that's also a challenge too, that you sort of have to draw a line in the sand and say, most of the challenges when they're going to occur are going to occur after this period post catheter insertion. If we want to look at quality metrics and potentially modifiable ways to improve access function. I'm going to turn to you, John, and ask you another question, something that I get asked a lot. So, I go and I speak and I talk about the importance of PD access and how it's such an important lifeline to our patients. And I hear the stories about surgeons that just aren't motivated, or programs that are having challenges engaging their surgeons and do have poor outcomes, though they're not measuring it as they should be. And hopefully Matt will help change the landscape on that. How do you approach a program that's struggling because of surgical motivation to learn and to improve? We'd love to clone you around the country and have you place PD access for all of us, but how do we approach that challenging surgeon or operator in particular regions where programs are struggling? And we're not talking about sort of large urban centers where there's 10 people to choose from. We might be talking about smaller centers where the pool of available surgeons might be more limited, for example.
I think this is a real challenging problem, because I've been faced with that same question. And actually, I've been sent to some of these locations where they were having major challenges. And, sometimes it's just related to the fact that the surgeon has not had adequate training or doesn't understand the importance of what they're doing. And I think also, again, we get back to this financial aspect of it. So you try to encourage them to attend some of our training programs. We do give a kind of an access awareness lecture that will hopefully stimulate them to want to pursue additional training, or at least personal investigation on how to improve their outcomes. But I think it's going to be a continuing problem. I don't have a good solution for it. It's very frustrating.
Yeah. And, of course, as the nephrologist, it is very difficult to have these conversations, because it's sort of like who are you to tell me how to do surgery? And I think what I've tried to do is connect surgeons with people like you, people locally in Canada, for example, like Dr. Penner. I know there's Dr. Wernsing as well, who places PD access, just to get the colleague to colleague discussion happening. But I do think that, again, it comes back to reimbursement and interest. I do think that we really need to consider a change in policy and reimbursement to spark interest into improving outcomes. I think the study from Japan shows us that we really do need to measure these outcomes. And I'll be really excited to see more come out from the North American PD catheter registry that will continue to push policymakers to measure and track PD access outcomes, because it's so important.
Mm-hmm.
Just a question for you, John. When do you think we're going to see a refresh, or when would you see what the right timing would be to think about an updated PD access guidelines with the ISPD? And I'm not going to hold you to it, and I know that there's a whole guidelines committee that reviews that, but I certainly see a lot of interesting stuff that has come up in the interim in the PD access space. So what are your thoughts on that?
So where do you think the deficits are in the current access guidelines?
I wouldn't say deficits, because that's something negative. I would say, what could we contribute? What could we add or provide something additional to that exists beyond? I would say, one thing that I thought of, and I'm just throwing this out there, is it seems like it's a lot to talk about best practices for placement. There's sort of the surgical and technical aspects of placement of the multiple techniques, and then there's the managing complications and measurement. It almost seems to me like we might even want to think about a position statement on how to measure and report PD access outcomes as a body, and then the PD access guidelines would also supplement. The PD access guidelines might focus on best practices for insertion and complication management. Just a thought. It just seems like there's just so much evolving in how we're measuring it, what works, what doesn't, what's a practical approach. So I wouldn't say deficit. I would say there's just so much out there, and there's such a wealth of knowledge in those existing guidelines. It's just expanding on the topics that have been covered. Okay.
So I could see where we could probably expand on the part about the measurements, how to document the outcomes, and maybe be a little bit more in detail about the auditing process. There really, in my opinion, there really hasn't been a lot of additional movement with management of complications with regards to the PD access itself.
You're probably right about that.
The thing that we don't have, and we ran into this when we did the ISPD guidelines for catheter-related infections, there's really not a good outline of how to approach salvaging catheters for catheter-related infections.
Yeah.
We went round and round with that in trying to get that fixed in those particular guidelines. So that's certainly an area that could be improved.
The other thing I'm thinking about, again, I'm just throwing ideas out here, and Anna Figueredo mentioned this actually when she wrote an editorial about the infection guidelines. It almost seems like sometimes when you describe a catheter salvage procedure, for example, it's almost like, you'll understand this in 3 minutes if you watch a video about this or a multimedia illustration. So it almost seems like maybe we could make these guidelines come to life by having links and access to simple videos that can demonstrate some of these. You can sort of click on the guideline and they'll take you to a supplementary material with a video to show you this procedure.
Yeah, that would be good. But we don't often get to plan our infectious complications in advance to get a film crew there.
Right, right. No, we'll have to follow you with a film crew for 2 years. Then, John, we'll call it Dr. Crabtree, the documentary.
Yeah, none of the chickens had previous abdominal surgeries, if I'm not sure. And the data shows that nearly 22% of these people, the patients, had previous abdominal surgeries. And being on Matt's paper there was a lot of discussion about that. So question to Matt, right? This is nephrologists, open catheters, open surgeries with previous abdominal surgeries. What are your thoughts about that?
Yeah, we have a couple papers we're working on now looking at the role of previous abdominal surgery on catheter outcomes, and also the role specifically of adhesions. They do have impact, particularly adhesions, even when adhesiolysis is practiced. So one of the things that struck me as you were having those conversations is I think we need to move beyond the theoretical measurement or what the recommended measurement and move towards actually measuring it in programs. I think that to me would move things forward. So if we could agree and we have a good yardstick with the patency calculation, and this Japanese paper shows that they've calculated across their systems, I think we need to start really looking at what our performance is, just like we kind of know our peritonitis rate. And I think that will help us start to understand if a program is struggling, what are their numbers looking like, and what's that associated with. I think that would be an improvement. And the second component of that is case mix. So, if you're doing, one of the challenges comparing percutaneous versus laparoscopic insertion is that laparoscopic surgery is being done on the more complex cases. So you're not measuring apples to oranges when you look at those two comparisons. You must adjust for case mix. And that's another important point. So for example, if you have a lot of patients in your practice that have prior abdominal surgery or adhesions observed at the time of surgery, they are going to have a higher complication rate. Their patency will not be 95%, I don't believe, at 1 year. So that's kind of resetting things as well. So sort of that to me is where I think we need to move forward.
But is that data in Japan even at all obtainable in a program?
It's a great question, but we don't actually know because we don't have that number at our fingertip, right? Like John and the guidelines say 95% patency at 1 year for advanced laparoscopic techniques. So, and 80% for other techniques, but we don't actually know what programs are achieving. And we hear a lot about, we have great outcomes. We don't have any problems. Our operators are great, whether it's radiology, nephrology, or surgeon. But when you say, what's your what's your sort of what's your number, what's your patency number at 12 months, nobody has the number on their finger.
Yeah, and then the other thing you just made me think about, and again, I'm quoting your work, is you've shown that when you systematically evaluate people for PD and you ask people what the issues are around eligibility, previous abdominal surgery comes up pretty high up there, right, Matt? As what people perceive, not actual, what people perceive as a contraindication to PD, which of course we know we can overcome with the resources and the detail and the expertise of the techniques that John has described with advanced laparoscopic placement. But it just got me thinking in Japan, and I'd love to hear what the authors would think about this, is remember, in Japan, only 1% to 2% of all patients with ESKD actually get PD. And you do wonder upstream what the eligibility algorithm is for PD in Japan. And would someone with extensive abdominal surgery, or would somebody with, we might call a slightly complicated abdomen, not even be offered PD in the first place? So is their experience based on already pre-selection of a different case mix? And I think that in Canada, for example, in the UK and other countries, I think that there's probably a lot of variability in what we perceive eligibility for PD is. And certainly in my program, previous surgery is not an absolute contraindication to PD, which can be overcome. So it's interesting, you do mention that case mix, and that might be something that's predetermined upstream from the population of patients that are in our study, in that study in Japan, in this issue.
I think there is some evidence that they did have some of that, in that they did remark that the patients who were more complicated were more apt to be referred for laparoscopy.
Right. And even more complicated than that, hemodialysis, maybe. We just don't know.
Right.
The BMI, the mean BMI was 23.2.
Yeah.
Wow.
Yeah.
I don't think I have a patient with BMI of 23.2 in PD.
Right. Yeah, ours average almost 29 to 30.
Exactly. So it's comparison is difficult.
Yeah.
Yeah. No, and of course, that's going to be something that will make the generalizability to other parts of the world a little bit more challenging. But I do think confirms that at least, in the hands of the operators in Japan, with the investment they've made into PD access and the real attention to detail, that outcomes are achievable, that are really quite excellent, and really a model for us all to continue to learn from. And I think that it really does behoove us to, as an international community, learn from each other on best practices for PD access, but also appreciate that local solutions will require some modification of the way things are done in other parts of the world. Any final thoughts, Matt, on where you'd like to see PD access go? In a perfect world, if you're given carte blanche, what studies do we need to do? What policies might we need to put into place across countries? This is pie in the sky here. What do you see as some of the major challenges right now that as a PD community we need to work forward on?
I think a big challenge is that if we're going to measure these things, we have to engage the operators who are putting the PD catheters in. So in the PD catheter registry, we have over 100 operators at 22 different sites across North America, and some of them are clearly engaged, but unfortunately some of them are not. For example, won't answer emails. So, I think in order for us, if we're going to create a quality report, first of all, if we're going to go to the step of actually measuring our outcomes, we have to really try to engage those operators and ask them, how can we do this in a way that's helpful? We don't want to be blaming people, but we want a report that you find useful. And that could even be extended to industry who make the catheters. It could be extended to regulators or payers who want to evaluate for performance. I mean, that would be my sort of pie in the sky, is that we have a sort of a report that we all use, that we all value, and can be used to drive better practice.
And we've just had, the holiday season is coming upon us in many parts of the world. Invite your access operators to your holiday parties. Get the open lines of communication open. Over a drink or two, it might be more easy to discuss the access challenges at your center and establish a rapport. And I can tell you that in my program really goes a long way. And I think that the more that they feel how important they are to the success of your program, and the more you engage them in as part of your practice, and even get to meet some of the members of the team, I think it all comes down to like a team approach. John, last words from you about this, and maybe I'll just ask you, how did you get so engaged and enthused in PD access? Did you wake up one day and have an epiphany as a general surgeon? This is what I want to do. So if you could answer that, I'm dying to know. And then your final words on sort of where we need to go with PD access.
So when I was hired for my particular medical group, I was the youngest surgeon in the group, and we just opened up our in-house PD program. And so the chief of surgery's finger swung around the room and it landed on me. So I became the PD access surgeon, designated hitter. And of course, working with the PD unit and with our nephrologists, which were fantastic, you did become part of the team. and that really is a fulfilling aspect of it. And I think this brings up something I wanted to mention. One of the things that one of our nephrologists did in Southern California was bring a surgeon to lunch program. And what they would do is they would invite the surgeon over to the PD unit, little finger sandwiches and what have you. The nephrologist would present a short a program about the medical and economic benefits of PD, and they would meet the PD nurses. They would tour them through the unit. They would plant a patient in there who was undergoing training. The surgeon would see a cycler machine that they had never seen before. And this really kind of bonded people together, and the surgeon did feel part of the team. And that was pretty successful in the limited area that we practiced that in Southern California. So that might be something that we could still do. And it kind of, like you said, they become part of the team. The other thing we didn't touch on, we're probably out of time, is that one of the problems we have in the United States, and I think this was described before, is that our PD programs, or our residency programs and fellowship programs, do not have set requirements for training in PD access, especially in general surgery. And this is where the ACGME in the United States has kind of not helped us out with this. They have requirements for vascular access, but they have not established criteria for PD access in their programs. And I think even Matt, you can probably follow up with this in the paper that you published with the 500 laparoscopic cases from the North American PD access registry. Only 51% of the residents participated in the access procedures. So I think this is where something that should be addressed.
Right. So we also need to invite residents to lunch too.
All right. I think we are about done here. Thank you so much for this absolutely entertaining podcast.
And that's a wrap, folks. Thank you for listening to this exchange. Links to the paper, our Twitter, X handles are in the show notes, and please reach out to us with your comments and suggestions. This is Jeff and Nikhil signing off until the next PD exchange. Take care.